Task Force meeting, Wednesday, January 27th at 5:30 p.m. First, I'm calling this meeting in order, and we'll do a brief roll call. Let's see. First is Eddie Chacon.
Present.
Luis Chacon.
Here.
Don Gosney.
Here.
DeWanda Joseph. Randy Joseph.
I am here.
Kristen Killian Lobos.
I'm here.
James Lee. Armand Lee. Shirley Leslie. Laura Mangles.
Present.
Marcus Njisang.
Here.
Tanya Polito.
Present.
Joey Schlemmer. Deborah Small.
Present.
Andres Soto. Nakari Sion. Ben Terrio.
Present.
David Tucker. Tamisha Walker. Linda Whitmore. And BK Williams.
Present, Linda Whitmore.
Okay.
Sorry.
I saw you, so my mind was like, oh, I see her. But okay, yes, thank you for saying that out loud. Okay, so meeting procedures are, we did not have any written public comment submitted today. So if you would like to make any public comment or speak on a particular item, then use the raise your hand feature we will call out that there is a 2-minute time period for you to be allotted to raise your hand, and we will begin allowing the speakers to speak, and they will be called on in the order that they raise their hand. And each speaker will have 1 minute to speak. And if you are calling in by phone, please press *9 to request to speak during the public comment or time period, or during following a particular item. Something is on me. Okay, so with that, we will start with the public comment. Or Ben, you had a question?
Yeah, that's for the task force members as well, right?
No, that's just for public comment and for.
Sorry. Okay, sorry about that.
Yeah, that's fine. So we're going to go ahead and start the public comments portion of the meeting. And Stephanie, will you start the 2 minutes? At this time, if any attendees would like to speak, you have 2 minutes to raise your hands.
I'm starting now. So far, we have one speaker signed up, Marisol Cantu. Marisol, you have 1 minute. You may go ahead and start.
Hi, thank you so much. I want to say I appreciate the community roundtable discussion that was held last week, and I want to encourage the task force members to hear those public comments, to hold them as you move forward in your work. And I encourage the youth here to speak their minds, especially some of the younger folks that maybe have been overshadowed in certain times. And I would also like to suggest that the task force think about the community supports, the community conversations. Instead of an hour and a half, there were a few people like myself that weren't able to speak, and maybe thinking about making that community conversation longer or without any type of disruption to the community members that want to speak. Thank you.
Thank you. And she is our only speaker so far. Stephanie, do we have any time remaining?
There's 30 seconds left.
Okay.
Okay, the 2-minute time period has ended to raise your hand.
And we have no more speakers.
So that ends the public comment portion of the meeting. So for staff reports,
Can I ask a question before you do your staff report?
oh, yes, ma'am.
Yeah, it's about the speaker who just commented, because I'm going to facilitate one of the sessions in March. And I didn't understand what she meant by disruption. So how were they disrupted, or what happened? I was there and I'd like to know, so maybe we don't do it in March, so I don't know what happened. What do you mean by disruption?
What I can do is I have Marisol's contact information. We can have an offline conversation with her about that.
Okay,
That we can,
I'd like to follow up so that maybe we can correct it for our next session.
and each session, that kind of segues into my staff report. I wanted to talk a little bit more about the roundtables because I am having, or we are asking that, we have volunteers for each session to facilitate, and there's lessons learned, and then there's also maybe new things to try, but each group of facilitators has quite a bit of leverage on how they want to manage the session. And so there was a scheduling conflict, so we need another facilitator to volunteer, or someone to volunteer to be a facilitator for the February 18th roundtable session. If anyone here would like to do it, please raise your hand.
Which one is that, Joanne?
February 18th is the homelessness subtopic or focus area. Randy, you have your hand raised to volunteer to help facilitate?
Yeah, if nobody else is raising their hand, yeah, I'd love to facilitate that.
Okay.
I have a question. Randy, are you doing another one already?
In April, but if nobody's raising their hand, I have no problem doing double duty. Homelessness is something that I care about too, so I have no problem facilitating as well.
Yeah, I can do it as well if
And if Tanya
to
wants
have support.
Let me double check. I think Luis is the other. Is it Luis or Eddie?
I volunteered last time.
Okay, for February, right?
Yeah, and I'm still down.
Yeah, okay, so, but besides you, we needed one other person, but because I don't want to have more than two, I think it gets.
right. So I defer to Tanya.
manage.
If Tanya wants to do that, volunteer, I defer to her. I only volunteer because nobody else raised their hand.
Okay, so Tanya, you would do it? Okay,
Yes.
okay, I will, you guys will be getting an email from me soon, within the next 3 days. Okay, so that's done. Also, if you guys noticed, there was no minutes on the agenda to approve for tonight. From here on out, we will be having the minutes brought forth at the second meeting of the month, which is the working group meeting, in order to preserve as much time as possible in the presentation and informational general meetings. And then also the subgroups for the second meeting of the month will be, the working meetings for the subgroups to report out and for you all to start engaging with the work and getting your recommendations formulated and everything. So we have created a shared folder with separate folders for each group so that there will be shared documents and shared information in those folders. So we'll be sending out an email with all of that information following. It'll probably go out tomorrow with the link. So that way reports and things can be reviewed by the entire body throughout this whole process. And then also, if your group meets and then you guys have requests of staff, whether that's me, Lupe, or Stephanie, or from anyone else in the city, please can you send that under like a separate document so that we can go ahead and disseminate that information. And what we'll probably do is create like a running form so that we can make sure that that information is publicly and transparently available. And then that way, once we get the answers or the requests completed, then we can have that available for everyone. So, and then I also do know that there may be times when like let's say this is an example, a subgroup has asked for finance or Belinda in particular to make a presentation. We do have a presentation for budget scheduled. However, it's several months from now, I think it's in May. So if you would like to get information from her prior to that, it may just be where like a subgroup goes to her directly, or I can help facilitate a meeting where she can just offer that information prior or help you inform your report, and then bring it back to the whole group, and then we still have the informational presentation later. So those are all possibilities. Let's see, the other thing is the request for the committee to nominate or to elect co-chairs is a recurring request that has been coming up. So we are going to go ahead and send out a poll and a questionnaire to the entire group. So if you can look for that in the next couple of days in order to manage that and in order to preserve as much time as possible, because we don't have very many months left for that. So it seems like that's a priority for this group. The other thing is, I just want to reiterate and really encourage everyone to visit the website that we have. We're not constantly, but we consistently update that website and make changes. We upload documents, we upload presentations, the minutes, everything is there. So a lot of questions that you may have or that the public may have, please look for it there. We've tried to be as comprehensive as possible. If you see something that's not right, please let us know. If you see something or you don't see something that you want to see there, also please let us know. And Randy, you had a question.
Yeah, so all the presentations, including the one that the police gave last time, is on the website, correct? Does it also include some of the questions and answers that was asked that she said that she would have? Would that be also included in the presentation, or would that be like a supplemental thing?
Well, so what we're doing is their presentation, whatever they showed on the screen, is like a separate, just a PowerPoint presentation.
Right.
The meeting itself, the recording is on there,
Okay.
like whatever the discussion was at the time.
Okay.
But we are also collating like questions that may have come up that didn't necessarily get answered in any of the presentations, because I know that there were a couple things even in the last presentation that were asked during public comment and that we didn't necessarily get to. So those are being collated in order and disseminated to staff to make sure that those answers are, public. And then also the comments or questions or whatever from the roundtable sessions are also being collated into a document and disseminated. So which is why, you know, I want to have some similar formatting for the subgroups to make sure that we're getting as much information as you guys are asking from us or from the public or from whoever, it will be available.
Okay, thank you for that.
Some kind of way. Yes, Don.
I just wanted to comment on something that Randy, or you mentioned to Randy about the videos being on there. I know that the city still is using Granicus, which makes it difficult to download the videos and so that you can pull them apart or archive them. I just want to make sure that they're very gracious in allowing me to record the meetings, and I try to send out links both for Google Drive so you could download the meetings or the videos, and they're on YouTube as well. So if any of the group is not getting the emails that I'm sending out, please just email me or we'll put it in the chat box tonight with your email address. I'll make sure that you're included in the distribution list. But we're trying to get them out as quickly as possible and in a format that can be usable.
Thank you, Don. I appreciate that.
And again, I thank you for allowing me to videotape them or to record it.
Ben, you had a question or a comment?
Yeah, I just want, first of all, I want to say, Joanne, you and Stephanie do a great job. Thank you very much for all you're doing with the website, both on and offline. And then for Randy, if you go back for last Tuesday at the council meeting, if you pull the documents off of the city's website and the council website, it's more or less the same presentation that was provided to the task force, just if you need it for your records.
Okay, thank you. Yeah, I just wanted to go over it. Okay.
Yeah, it'll just make it easier than trying to just jot stuff down from the video.
I appreciate it.
Okay, so we are going to, I think that's pretty much all I had. So thank you to Contra Costa Health for coming this evening. They will be presenting to us per the members' requests for them to tell us a little bit about mental and behavioral services that are provided to the city of Richmond. And I would like to introduce, well, Suzanne Tavano, can you please introduce your team that's here with you? And we have, Stephanie, are you gonna do the presentation or can you, I know we wanted to share that.
I downloaded it, so I can present it unless someone else wanted to.
If you can, please.
Yeah, I'll put it up right now.
Thank you.
Joanne, while they're putting that up, can I give a very brief staff report on behalf of the PD?
Oh, pardon me. I didn't even ask. Are there anybody besides Tim? Is there any other interdepartmental staff here that would like to make a brief report?
I'll make this really brief, you guys, because I know we want to get into this presentation. I just also want to start with just saying thank you to Kristen and Deborah. You guys did a great job at the first roundtable meeting. Clearly, you're passionate about that subject, and you just did a wonderful job, and I wanted to make sure that you were recognized for that. Thank you. The quick staff report from the police department, I just wanted to let everybody know that the chief has been meeting with multiple service providers around the topic that was discussed last week of mental health and mental wellness. I mean, even all the way up until today, I know that the chief and Michelle Milam, who's on this, a staff member that's on this call right now also, have been meeting multiple times, and we are looking at ways to leverage the existing services we currently have to try to deploy resources more efficiently, better, look creatively out of the box. We're looking at all multiple venues for funding sources. We know that the city's tapped, so we're looking at grants, and we're looking at other potential funding sources to try to get creative to bring money to the table to address the need for mental health and mental wellness from a different perspective than a police response. So I just want everyone to know that we engaged and we heard that presentation, and there's a lot of information in there to digest, synthesize, analyze, and look for how we can do certain things maybe differently. And I just wanted everyone to know that we're diligently trying to put our minds at work to figure something out. So That's my only staff report.
Okay, so Suzanne, you're up again.
Hey, hello, everybody. And I see that our team member, James, has joined us now, and you're not in the car, James. It's very unusual. So hi, everyone. I'm Suzanne Tavano. I'm the Behavioral Health Director for Contra Costa Health Services. And with me this evening are my partners here. Fatima, do you want to say a word about yourself?
Good evening. Buenas noches. My name is Fatima Matasol. I'm the AOD Program Chief in Contra Costa. I'm responsible for substance use services. Thanks, Suzanne.
Sure. And James, how about you?
Yeah, my name is James. I'm the president and CEO for Richmond Chamber of Commerce.
Oh, thank you. I also met James Lancaster.
Hello, good evening, everyone. My name is James Lancaster. I am the clinician with the mental health evaluation team, and I partner with law enforcement along with Richmond Police Department in corresponding model for mental health.
Thank you. Well, just to start off, thank you everyone for inviting us to be with you. And I'm really sorry I missed last week's meeting. It sounds like it was really informative and robust. So sorry I missed that one. But for today, we prepared a little PowerPoint, but we're going to do it super fast because I know that you're probably more interested in a dialogue and Q&A and so forth. So maybe we could just go through this pretty quickly and then we can have more of a conversation. So one of the things we were asked about is funding. How does funding work for the county? And I'll get into that in a moment, but maybe we could go to the next slide. Because I'm just going to do some really high level overview stuff here just for orientation. My guess is many of you already know this about us, but just in case. So the Behavioral Health Division includes mental health services for specialty mental health services and substance use services through the Drug Medi-Cal organized delivery system. We're one of the counties who opted in right from the beginning, and thankfully we did. So we have 3 major contracts with the state, with the State Department of Healthcare Services. One is to provide specialty mental health services. And so those are services that are for people that meet certain medical necessity criteria. And the bar for that historically has been pretty high, but we've been negotiating with the state about being more flexible about the medical necessity criteria. They're pretty rigid and we're not able to do everything we would like to do. So a lot of negotiations and advocacy going on around that. So that's our specialty mental health services contract. Then we also have a contract to provide the Drug Medi-Cal organized delivery system in the county. And then our third major funding source for the system overall is the Mental Health Services Act. And then for both mental health and substance use services, we receive different block grants, and we apply for grants whenever we can. And as we all know, they're a little tricky because you get the funding and it might be good for 3 years, and then you have to figure out how you're going to sustain the programs you lifted up. And so we've certainly been running into that lately. In fact, our MET clinicians initially were funded through a grant through the state, the Mental Health Wellness Grant, and that expired in February. So we had to figure out how to fund our existing MET clinicians because we want them and they're valuable. So we figured out a way to do that. So grants are great for increasing capacity, but then there might be a cliff, and you always have to watch out for that cliff when you're approaching the expiration of the grant term. So those are kind of just some broad perspectives. I think there's a couple of things I would say in general. There is a bit of confusion about mental health benefits. I really don't like separating mental health and substance use, but sometimes we need to because as much emphasis is put on integration at both the federal level and the state level, the funding is still completely siloed and doesn't overlap. And so and the regulations generally are the same, but not entirely. And so it's still two systems, administratively, financially, et cetera. But what Fatima and I tried to do is kind of work around all of those limitations that are placed around funding, and actually at the service delivery level, actually start integrating our services increasingly, which we've been doing for the last 3 or 4 years. So I've been making some big progress there, but hopefully again, with more negotiations with the State Department of Healthcare Services, we'll be able to blur those lines a bit more in the future. So those are just some general comments. Our contracts with the state are a little funny and not always understood. The contract for the specialty mental health services, we're considered a managed care entity by way of that contract with the state. And we're subject to all of the managed care rules. Back in the 80s, 90s, when this was all starting, wasn't so much, but in subsequent years, particularly since the passage of the Affordable Care Act, all of the requirements that other managed care entities have slowly but surely been applied to us. So it just adds a lot of administrative burden to what we're doing. So in many ways, we're probably more similar to Kaiser than other entities in that we're both a managed care program and we're an actual service provider. So we have that dual role. Again, not always understood, at the community level. For the drug Medi-Cal organized delivery system, that's part of a waiver to the state plan and other complicated state funding mechanisms and regulations. But there's every intent for the state to continue the DMC ODS program, as it's called. Not all counties in the state opted in. It was a voluntary opt-in. And again, not all counties have done it. And so there are variations from county to county in terms of what substance use services are available to their population. Again, depending on whether they stayed with the old state drug Medi-Cal system or moved into the organized delivery system. And I can talk a little bit more about that, as can Fatima, in a moment. So just at a really high level, in terms of our responsibility as a mental health plan with the state, we're responsible for providing all specialty mental health services to all Medi-Cal beneficiaries in the county, regardless of where they might receive their physical health care. And maybe this is a little too technical, or maybe you guys know it already, but in Contra Costa, there are 2 managed care plans for Medi-Cal beneficiaries for physical health, and that's Contra Costa Health Plan, so CCHP. And then the other one that people don't speak about so much because there are significantly fewer Medi-Cal beneficiaries enrolled is Blue Cross. So those are the 2 managed care plans for physical health. For specialty mental health services, we have the responsibility regardless of where people get their physical health. But there's another little complicator here in that back when the Affordable Care Act was passed, they did create benefits, mental health benefits for people who had mild to moderate mental health needs. Those didn't exist before. So there was really a large portion of the population, Medi-Cal population, who just didn't have access to mental health services, because if they didn't meet the kind of high criteria, the high bar for specialty mental health, there wasn't very much available to them. So we did a lot of advocacy around this for a number of years prior to the ACA. And then with the ACA, the mild to moderate mental health benefit was created. And so CCHP and Blue Cross are responsible for that level of mental health care. With CCHP, they basically entered an MOU with us, behavioral health, to also help manage the mild to moderate benefit through our behavioral health access line. So it's a little confusing to people at times, but they're really 2 different mental health delivery systems. operating under one access point, but the rules and regulations and how you access those services and who's eligible for them, there's significant differences there. And I know it's really confusing to the community when they call the behavioral health access line and they're asked a lot of questions, and the questions really are to determine if they meet the criteria for specialty services or if they meet the criteria for mild to moderate. So that's probably more than what you want to know, but it's a little background information. So again, mental health, we're responsible for every level of care under specialty health that Medi-Cal beneficiaries in Contra Costa are eligible for. And as long as a Medi-Cal beneficiary retains our county code, the 07 code for Medi-Cal, wherever they travel around the state, we're still responsible for ensuring that they receive the services they need and authorizing those services and paying for them. And as we know, people do move around the state for a variety of reasons. And so our network is both in county and out of county, and sometimes statewide, depending on where the person is traveling. So this pyramid really starts with our lowest level of care, which is really prevention and early intervention. Medi-Cal does not pay for any of that, no prevention, no early intervention. Medi-Cal still operates pretty much on kind of an illness model. And so prevention and intervention is not a covered benefit. So the way we fund that is through the Mental Health Services Act. And then the next level up would be our outpatient clinics and programs. And from there, more intensive services, wraparound services are available through our full service partnerships. And then the next level is when people need residential care. And after that, our crisis services, and that might be at PES, Hope House, Nyreka House, Nevin, etc. But in particular and increasingly our 3 mobile crisis teams. And then at the top of this pyramid, not because that's where we want people to go, but because it's the most intensive and in many ways the most restrictive levels of care and also the most expensive. So it kind of sits there at the top. Our goal is to do everything we can to stop short of crisis services and definitely stop short of inpatient hospital services. But, there are times when people actually need a hospital level of care. So that's the inpatient part. And as you all know, Contra Costa Regional Medical Center had one unit, Unit 4C for inpatient psychiatry. And being able to use the emergency regulations under COVID, we were able to very quickly reopen the former 4D unit and currently have a capacity of 12 there. So 23 beds are on 4C and 12 beds are on 4D. So those are our local hospital beds, but we also contract with John Muir, both for services, inpatient services to children and adults. And then we contract actually with hospitals throughout the greater Bay Area and beyond, because there are just not enough hospital beds to accommodate everyone in a timely basis. And so we really stretch pretty far out to find hospital capacity. So it's a pretty broad network. That green box up there, state hospitals, and that's predominantly Napa State Hospital, not too much metropolitans in Southern California. State Hospital, again, another level of care. If anything and everything we could do to avoid that level of care is what we try. But in the end, people sometimes need that long-term locked hospital level of care. More times than not, there are people that have been through the justice system and are found incompetent to stand trial. And that's where more times than not, they will be placed for restoration of competency, but also some people who are on LPS conservatorship, so no criminal charges involved at all, sometimes are in state hospital when all the other levels of care just aren't sufficient for adequately treating that person. So, once people get up to these higher levels of care, we're working right away to try to get them back down. Our goal is to get everybody back into the community and living successfully within Contra Costa. So the right-hand side of this chart is all of the steps that often need to be taken once a person gets to state hospital. Almost always we have to go through these various steps to get them back into the community. With local hospitals, sometimes we can skip a step or two, but more likely than not, those clients are going to go through this progression of care as well. So that's kind of high level. And then I don't know if we go to the next slide, I don't know if it's really there or not. It was there this morning. Oh, it is here. Yay. Okay. When I was looking at it about 5:20, it had disappeared. So thank you. Fatima, do you want to do this one and talk a little? This one's a little different. It's about levels of care, but in a different way. And in the substance use world, there's a lot of talk about numbers. And so maybe Fatima, you could explain what the numbers relate to.
Yeah, thanks, Suzanne. And you know, the substance use system is based on the foundation, on the medical model, really, but on the basis that prevention works. It is a disease that is preventable. It is a chronic disease, but it's manageable. And also for people to decide that they're ready for treatment, there's a number of steps. There's no such a thing as somebody accepting to go into treatment overnight just because we all want them to be in treatment. So, and I think that's very important to understand the concept that you have on the screen, because as Suzanne explained, is based on levels of care. Unlike the mental health system, people don't have to start at the very top or at the very bottom. People need to enter the system, and we reassess people on an ongoing basis. And depending on the presentation the person has, then they're placed on that level of care. So for those who are familiar with the old system, if you enter on a particular level back in the days, that person would be stuck in that level of care for a long, long time. The new system under the drug medical organized delivery system that uses the American Society of Addiction Medicine criteria, individuals are able to move through all those levels of care. So somebody can enter into withdrawal management for detoxification. We will assess that person for medical necessity in that level of care, but then from there they would move to the next step. So and then as important is our prevention services. We always had prevention from many, many, many decades ago. And we know that if we front end services at the onset, we're able to prevent the disease. And in many cases, it has to do with environmental factors in the community. So the more retail outlets, for example, there are in a community, the higher the likelihood that problems associated with alcohol will be concentrated there. So some of our funding is dedicated to do prevention activities, services in the school, where we're showing parents and kids how to make good decisions, how to have good parenting and good communication to prevent the use of substances and the escalation of those. So what you have on the screen there shows, you know, the highest intensity is level 3.5. That is residential treatment, and people don't have to stay there for a long time. They can step down into level 3.1. That is the most widely known level for substance use. That's what we always had. And then it's 3.2, that's withdrawal management. That's what you used to know as detoxification. People go there for maybe 3 to 5 days. Hardly they stay there for 7 days. And the whole idea is adding a strong component on case management that can support the coordination of the care that the client needs so that they can move to the other level, which could be intensive outpatient. That's a new addition under the drug medical organized medical system, because it includes a lot of counseling, but it allows individuals to start testing some of the wheels and the tools that they learn in residential treatment And as part of the DMC-ODS, we have added what's called recovery residences. When combined, intensive outpatient or regular outpatient in a recovery residence, then individuals can succeed and continue working on their recovery as they re-enter society. So those are additions that came only through the drug medical organized delivery system. So it is a good addition for the Richmond area. I particularly want to refer to the Richmond Health and Wellness Center that we opened in September. That facility combines withdrawal management 3.2, residential treatment 3.1, and 3.5. It's a multi-level facility. Another feature, I guess, of the substance use system is that we have programs specific for some populations. For example, our perinatal programs, which provide services for pregnant women, for women who are parenting small children. And those programs generally have childcare, transportations for the moms. We coordinate with the doctors so that they continue their prenatal care when they're with us. So it's a very nice addition to the system. And finally, I do want to talk about medication-assisted treatment, which has grown and expanded as a result of the DMC-ODS, and it adds buprenorphine as a medication, Vivitrol for alcohol, and a variety of medications that we didn't necessarily use in the past because what you know mostly is methadone. And with that, I will stop so that Suzanne continues her presentation.
And, and Fatima, thank you. For years, we would go to presentations about bending the cost curve. There was, at the national level, the state level, lots of presentations about bending the cost curve. And what was always highlighted that the best way to reduce physical health costs is to treat substance use conditions. And so it was always rather puzzling why everyone would acknowledge that, but the funding for substance use services has always lagged so far behind the funding for mental health services, and that's not even where it should be. So it's something of a schism there. So thanks, Fatima. And why don't we go to the next slide? And so I know we were asked about funding, and our funding comes to us from the state. It's kind of bulk funding, and then it's assigned to different programs throughout the county, both for mental health and substance use services. So it's not like there's a dedicated percentage per region of the county. So it really, the funding is really distributed based on the needs of the community and the programs we're able to get up and running to serve the people in that community. So this is just a pie chart that shows that. What I would say is I think we don't know what our operating budget is yet for 21-22. We'll see what comes out at the Board of Supervisors, but this is pretty much for 2021. And the combined budget for behavioral health, which includes mental health and substance use, was about 175 million last year. And the huge majority of that was on the mental health side. Again, trying to get substance use funded where it should be is a slow but sure advocacy issue. So we can go to the next one. So this just basically breaks down the percentages of what I was talking about. Maybe we could go back just for 1 second to that one. What I want to point out is when this lower big rose color, I guess it would be the darker rose color where it says Medi-Cal 31%. Medi-Cal is really a combination of local funds and federal funds. So if you look up and you see the blue 1991 realignment and the 2011 realignment, those funds are all tax-based. So what we get in realignment funds depends on how the economy is doing. And so as we know, the economy did not do well all of 2020 and is still continuing. So our revenues there are not where they used to be. They're lower. And the reason I bring it up is in order to get Medi-Cal, really that should be labeled federal financial participation. in order to get the federal dollars, for every dollar of federal money we want to bring in, we have to put up a local dollar. So it's almost a 1-for-1. And so those realignment dollars are really, really important, because in a way that determines how much money we have to match for federal dollars. And then when you look to the right and see that lighter color, coral color, that's the Mental Health Services Act money. And there, again, we're really funding prevention, early intervention. That's not a Medi-Cal service. A number of our innovation programs do not claim Medi-Cal, et cetera. But we try to use the Mental Health Services Act funds as much as we can as local match to federal dollars, because remember, for every dollar we put up locally, we get another dollar back from the feds. So we kind of double our money. So we're always trying to balance all of that out. So, so we can go from there to the next one. And this is the pie chart for funding that goes into AOD services. And again, you can see the federal financial participation at the bottom, that 28%, the green, that's what people usually call Medi-Cal. Medi-Cal really is a combination of local and federal funding. The state general fund is not so much in the game anymore because they did all of this realignment. And whenever the state realigns money from taxes, it realigns the responsibility for doing everything to the county. So they sometimes add more requirements than there is funding, but that's what we have to deal with. So that's just the big picture on the funding sources for AOD services. And we can go to the next one. And some of you probably have seen this in the past when I presented at the city council, the Richmond City Council meeting, I don't know, 10 months ago or so. I went a bit more into this, but it's really hard to explain easily what we do. And, you know, if we do a long narrative, it's really hard to follow. So this is a picture. So in West County, these are the adult mental health services available to Medi-Cal beneficiaries. And I would also say low, no income, uninsured residents of the community. We feel very committed to supporting the uninsured. Different counties have approached that different ways depending on how their funding has been. But we in Contra Costa have stayed very steady that if an uninsured, low income, no income person needs the services, we're going to provide the services. The staff have, you know, they're blind to it. They don't know if somebody has Medi-Cal, doesn't have Medi-Cal, et cetera. So they get the same level of services, which is what we want. So again, these are the array of adult services available to residents of West County. Sort of at the center of it is the West County Adult Mental Health Clinic. And as we all know, it's been moved to the new location at San Pablo. Very soon after we moved in, all the COVID restrictions came into play. So the clinic is still open. People are still going in, but you know, far fewer because we really had to switch predominantly to remote services. So that's kind of the core program specific to West County. And then, you know, we put all the other services that are available to West County residents, but might be located right within West County or might be located in other parts of the county, but West County residents are eligible for them. If you notice that box, so you see the blue box, West County Adult Mental Health, and then to the right, the sort of purple colors. These are all the agencies that we contract with. And you know what I have found over the years, I guess what I would say is I was with Contra Costa Behavioral Health for almost 20 years and then left for a while and went to Marin and came back. But we don't brand ourselves very well, and I feel like that's okay. But a lot of times someone will say, well, why don't you do X, Y, and Z? This agency is doing it. Why don't you, the county? What's usually not known is the funding for those community-based organizations often is coming through contracts that we hold with them. So always like to call them out because they're really part of our whole system of care, our delivery system. As far as the state is concerned, whether it's county staff or contracted programs and staff, it's all one delivery system, and everything applies equally. And then there are the countywide services, and then that bottom box, augmented board and care homes. Again, they're scattered throughout the county, but serve West County residents also. So that's just a snapshot for adult services. And then if we go to the next slide, it's similar for children's services. Again, the box at the top is the West County Children's Mental Health Clinic, and that's co-located with the adult clinic in San Pablo. And then it's the same structure. You can see the countywide services available. What's particularly different about this is our school-based services. Contra Costa for decades has been very committed to providing school-based services and have continued that. So these are all of our contracted partners who are providing school-based mental health services. And then it goes across. So that's snapshot of West County Children's mental health system. And then we can go from there to the next slide. And so I thought, rather than doing a lot of extra, what is behavioral health in general, it seems that a particular focus right now are what are our community-based crisis services apart from PES. So we're putting PES to the side and really talking about community-based mobile teams. And I know throughout the county, there's a lot of thought and consideration going. What I would say is really predating last Memorial Day, going back over a year, following the death of Miles Hall in Walnut Creek. We actually started working with police chiefs around the county about how we can better assist in responding to crisis in the community. And there was a fair amount of work going on. And then the mayors, the 19 mayors of the county, after May, really, it became a very elevated issue, a lot more discussions going on, et cetera. And so there's a committee of city managers representing the mayors who have been working with health services to really look at community crisis response. And it was the city managers and Anna Roth, our health services director, who co-sponsored a recent value stream mapping event. And some of you may have been a part of that, but it's really a very large scale improvement process where you really look at all parts of your system, really talk to a lot of different people to get all the information. So that value stream mapping about crisis services, the work is continuing. A design team has been formed. Some of you may be on it, I'm not sure. And so the work is going to take place over the next year. So just wanted to mention that. But in the meanwhile, I feel like while all of these larger plans are being thought through, don't want to stop whatever we can do now, because doing things now is important. So we're continuing to look at what we have and what we can do in the meanwhile. So we have 3 teams. One is the mobile crisis response team, one is the MET team, and another is the mobile response team. And if we go through these, you'll see the differences a little bit. So if we could go to the next slide. So, so this is the mobile crisis response team. It's countywide, and it consists of teams of people, a licensed clinician and a peer provider, someone with lived experience, who will go out first. Calls come in, there's some screening over the phone, and then in-community services are provided. When all of the restrictions of COVID, the shelter in place, et cetera, were going on, we had to move to remote services. But, with community-based crisis intervention, it's pretty tough to do that remotely. So we did mobilize and really resumed in-person responses. We're not going all the way into homes right now, but certainly to seeing people outside or right at the threshold of the door. So mobile crisis response, quite honestly, the funding for this is to support Medi-Cal beneficiaries. But what we also know is that commercial insurers don't have community-based crisis services. And that would leave a significant portion of the population without access. So we try to stretch as much as we can to serve non-Medi-Cal beneficiaries as well. But technically, that's supposed to be our target population for that. And we do operate 7 days a week, but not 24/7. Would love to get to 24/7, but that always becomes a money discussion. So that's the mobile crisis response team. I think there might be another slide or two attached to this. Yep. So, I should mention the mobile crisis response team, MCRT, really is serving adults and adults with mental health issues and adults with both mental health and co-occurring substance use issues. And I think as we get further down in our evolution, we'll stop making such a distinction. But then also you could see sort of Medi-Cal, some privately insured and definitely the uninsured. So that's, we can go to the next slide. Again, these are just the goals and what the team does. I think what's important to think about is when you think about responding to crisis in the community, it's not just what happens in that moment of the crisis, but it's really all that you try to do before the crisis occurs, and then the crisis occurs and you're intervening in the moment. But then what is really important is what happens after the crisis settles down. What's going to be put in place to support that person in ongoing ways so the crisis isn't recurrent. So that's something I wanted to add to it. We do follow people for about 30 days after the specific crisis event, just to be sure they're going to get engaged and connected to other services. So we can go to the next slide. And this is the referral process, and you all have access to this PowerPoint, so feel free. These are the numbers and the process. And what I would say is this: when these teams first started, almost always was it in combination with law enforcement. What we're really trying to do is move away from that model as much as possible. Try to get a sense of what's going on within the setting where the crisis is occurring, and make some determination whether we can adequately and safely intervene on our own, or if we really need law enforcement partners with us. Our staff are trained in verbal de-escalation, but beyond that, if they're in a particularly potentially dangerous situation, we really appreciate the presence of law enforcement. But what we're trying to do is try to do a preliminary assessment beforehand and not call on law enforcement as much. Or if we initially don't know, but then we get there and assess the situation and it feels pretty under control, then law enforcement can step back and not have to stay for the whole time. So that's an evolutionary step that we're taking now, and one that I would like us to continue to move forward with. So that's mobile crisis response. If we go to the next one, and we'll go to the next one. And again, these are the situations that are not best suited for our intervention. And I know this is a difficult one because people with cognitive decline, so Alzheimer's, dementia, etc., they're not, it's a really strange thing. They're not considered part of mental health's target population. They're really considered part of the physical health world. And so we're not really very well suited to intervene effectively there. We try, but it's difficult. So these are just the categories of people that are not part of our target population, but of course we at times end up interacting with. So we can go to the next one. I don't want to take too much time here. And then the mobile response team, There are going to be a lot of slides here. We can flip through them, but not spend a lot of time. The mobile response team, we contract with Seneca for this program. It's been around for at least 14 years. And I really like this model a lot in terms of not being reliant on law enforcement. So with mobile response team, again, it's intended for youth and their families in crisis. They'll do some phone screening, but then they'll do on-site interventions. And then if they're Medi-Cal families or uninsured low-income families, they'll be able to stay with that youth and family for about a month just to be sure the crisis is settling down. And during that time, be sure that they're connected to ongoing services. If people have commercial insurance, again, because our funding is Medi-Cal, they will respond and de-escalate the crisis and get the youth and family connected to other services, but they can't provide the ongoing care that they can for the Medi-Cal population or Medi-Cal beneficiaries. So this is the mobile response team, MRT, specifically for youth and their families. And they'll start with a phone call. Also, we can flip through these next few slides and just show them to folks and see. So, you know, this is what they do, which is pretty much what I just described to you. At times, they do need to initiate holds for involuntary care. And we're used to saying 5150s. However, with kids, it's really 5585 is the code section in Welfare and Institutions Code. So that's pretty much what they do. They also are pretty much 7 days a week, but again, they're not 24/7, but there is 24-hour phone support. So we can go to the next one. And again, this is pretty much what I was saying, primarily intended for Medi-Cal or uninsured, but we find it impossible and don't want to say no if someone with commercial insurance calls, because we know commercial insurers do not have this level of service available to their beneficiaries. So we'll go, if we can go to the next one. I think there are a bunch of these, yeah. So, and this is just describing who they are usually interacting with when they go out for an intervention. So we can keep going. So if we go to the next slide, I think probably we could get through the next two, yeah, and we can keep going. Yep. So this is sort of the flow chart. Again, these slides are available to all of you and you could certainly look at them. I don't want to take all of your time walking through them, but there are always two clinicians that go, and there are family partners that are part of this also, so that people with that lived experience are bringing that sort of expertise with them as well here as with the mobile crisis response teams. So we can keep going. And this is just more information. And but I would say that the mobile response team for youth does intervene quite a bit or responds quite a bit to calls from the schools. And we know that some schools are utilizing the service more so than others, usually when a 5150 is involved. But again, the goal is to avoid a 5150. It's to stabilize the crisis in the community and not have to sign a 5150 and send them by ambulance to PES. It's not the best, and we should only do it when it's absolutely necessary, is my feeling. So we can keep going, and we can keep going until we get to the MET. We can pass through this one also, but you all have them. So MET, I'm going to turn this over to James since he is MET. So James, do you want to take this and talk about MET a little bit? And I know some of your team members are here as well.
Hello. Yes. Yeah. So on this Zoom this evening, I have Officer Landy. Officer Landy, would you like to introduce yourself in your role with the mental health evaluation team?
Sure. My name is Officer Landy. I'm with the Richmond Police Department. I also serve as the West County Mental Health Evaluation Team Officer, and I work with James in responding to kind of follow up to clients who have had mental health crises, and law enforcement response to try to work with the county to mitigate any further risk of law enforcement contact.
And Officer Landy, I just want to say thank you so much, because I'm already hearing such great things about you. So the effectiveness of anything is in partnership, and it sounds like you've been a great partner. So thank you so much.
It's been a great program to join. I've really enjoyed working with the team.
Great. So James, want to take it away?
Yeah, so usually I give a complete kind of presentation, but if everyone is able to read this pretty much brief overview, just send the hand raise so that I know that you can actually see what's on this presentation currently. So I know there was a lot of comments that it wasn't large enough for everyone to see. So moving forward with the services that MET provides, it is county services. We also assist with anyone that has private services as well. The goal is to find the appropriate services for that individual. And what happens is that the MET team is conducting an evaluation. That information is coming from law enforcement on most hands, where they're having 911 calls that are going to dispatch. There could possibly have been some other form of criminal offenses, but law enforcement feel that this individual may need some additional assistance, and they would not want to move forward with any kind of criminal aspect. So sometimes the DA may get it. They'll say, we believe that this person needs additional assistance. Can we send our mental health evaluation team to follow up on this? So maybe they were experiencing a mental health breakdown at the time, and they made some wrong decisions. We are here to actually figure out exactly what is needed at that time. So some of the services that we provide is more so of the educational piece. Education is greatly needed for all populations, especially in the city of Richmond. A lot of people have a perception of mental health. They don't believe that they have a mental health disorder, or they're not accepting to a mental health professional coming into their home. I'll say about 85% of the time I have been in homes, I have been asked to come in, sit down, and been in conversations that lasted over an hour period of time, giving me great historical information to assist an individual, developing a plan for them to have long-term stabilization and remain in the community with no law enforcement contact in the future and no psychiatric emergency services. This is the goal for MET. We provide consultation and collaboration. We're in constant communication with the public, law enforcement, any city-driven providers that would like this information or this consult or additional education as well. We collaborate with all entities. So it doesn't matter if you're within Contra Costa County or if you're outside of Contra Costa County. We're able to navigate an individual and provide services for them in Connecticut on the East Coast if we need to. If they're in Contra Costa County, we will assure that there's a plan and we can safely get them to their place and be able to provide those services with another service provider in their area for network. Within county, we consult with PES, so that's psychiatric emergency. We consult with the inpatient facilities. We consult with the crisis residentials, outpatients, all of the community-based organizations, and all of the criminal justice system, as well as any law enforcement entities. In addition, we consult with Adult Protective Services, CPS, Kaiser, John Muir, and the VA hospitals. Probably some other entities that I did not mention, but there's a lot of work that goes into the services that we provide for the community. And like Suzanne said prior, is that, the funding sources, these are preventative services that are given and are not Medi-Cal funded. A lot of people in higher places believe that these services are needed within a community to be able to show the support as well as the well-being for individuals. Richmond Police Department has been the host of the mental health evaluation team for the last 6 years. It started in 2015. Since that inception of the program, prior we had Officer Souza. He did his five-year term, and now Officer Landy has accepted the torch. With Officer Landy coming on, we expect for there to be more, how can I say, additional services that will be provided for the city of Richmond, as well as the west end of Contra Costa County. There may be some services that individuals believe that may need a different model, but the mental health evaluation team is a co-responding model. And a co-responding model is stated as it's a preventative method. A lot of times people are in crisis, and when they're in crisis, they're unable to get the services at the time that are needed. Sometimes you can't make a primary diagnosis at the time. You're unable to treat because it may be a substance-induced psychosis, or they're just not ready at the time because maybe law enforcement contact, or they do not like psychiatric emergency staff at the time. The window of opportunity is always open, and that's where the mental health evaluation team finds their best niche in being able to provide these services for an individual to be accepting into any one of our programs that Contra Costa County provides. We then take them through steps of all the services that we provide. So we'll meet an individual from the community at their home from a crisis, and then we'll walk them through until they're stable and they're seeking outpatient treatment at a clinic, and they're going and they have a psychiatrist and a therapist if needed, or if they're or if in need of alcohol and drug services, they have a counselor that they're seeing on a consistent basis. So our services are not limited to just following up and providing information. It does take you into a sequence of services that the county offers, as well as the education for not only the individual, but the family and the community.
Thanks, James.
You're welcome.
And, I think, Fatima hit on this, and James certainly did just now, is, outreach and engagement is so important. There are there are just cultural differences also. Within some cultures, it's easier to say you have mental health issues. In other cultures, it's easier to say you have substance use issues. And then across the spectrum, it's hard to say you have any behavioral health issue. And so then it's trying not to, label people, label the services, but just try to figure out what people need and then help them access what they need to thrive in the community, or at least survive in the community. So not always easy. I know that there's a lot of frustration about how people are out on the street and are brought to PES on 5150s, and then they're right back out on the street again. I think a couple of things I would mention is there's some misunderstanding, a bit of misunderstanding. So a 5150 hold is good. It's in effect for up to 72 hours, but it doesn't mean necessarily 72 hours. And the other part of that is PES, even though it's a really intensive level of care, it's certified as an outpatient clinic, not as a hospital program. And so technically, people shouldn't stay at PES more than 24 hours. But the reality here is, and I hope the state's not listening in, if someone isn't stable enough, at the end of the 24 hours, I'm sorry, all my lights just went out. Sorry about that. I don't know if you can still see me or not. I'll fiddle with the lights in a minute. So, we will keep people longer at PES than technically what we're supposed to, but to get them stable enough to leave. And then also what happens is once people get to PES, their conditions do stabilize. And so they do, with some time and medication, look differently than what they did when they were out on the street. In many instances, once they're stable, they are going to return to the community. They're not going to be hospitalized, and it might be a repeating cycle. So that is what it is, but that is what happens. I think it causes a lot of frustration and misunderstanding within the community about why, if somebody is put on a 5150 hold, why is it a day or two later they're back in the community? That's the reason why. So so I think we'll stop there, and I'm gonna go off camera for a minute and see if I could get the lights back on and open it up to Q&As or discussion. So I'll just be right back. I'm so sorry.
So I'm available for Q&A along with Fatima until
So
Suzanne
am I.
returns.
Yes. Thank you, James.
Okay, great. Thank you. Yes, I was going to ask if they could unshare, but okay, great. So I know, Brian, you had your hand raised, but I didn't know if you wanted to just add to that conversation, or were you just saying you're open to Q&A as well?
I'm both open to Q&A. I just wanted to follow up on what James and Sam have been mentioning, which is kind of the role of the co-responder model here. Part of having law enforcement involved in the follow-up process is not only the linkage of services, but the ability to build some trust and rapport with community members who have been placed on 5150 holds, who have had kind of traumatic experiences, and finding a different conduit for them to interact with the criminal justice system if they're going to have some kind of contact. So by building relationships with the prior officer, with Officer Souza, or myself with the other Met officers, it often gives families and individuals who are having contact with law enforcement or PES a different point of contact when they need services. It allows us to kind of divert away from having police officers respond to an immediate crisis. It also allows us to, I think, work it by sharing information, really understand.
Yeah, I see that.
But it allows us to share information and really try to figure out when something that may have been classified as a criminal problem is in fact something that can be handled through mental health. But that's a difficult feat to accomplish without kind of constant communication across the different organizations.
And Officer Lenny, thank you for, that's a really important part, because, you know, all the studies of what's the best therapeutic approach, is it this, is it that? In the end, what it comes down to is if you're able to build a relationship with someone. And so that's key to, I think, all of the work that we all do, is really just trying to approach somebody as an individual and establishing some level of relationship. So thank you for that.
Okay, Marcus.
I have a very quick question. First of all, thank you for the very extensive presentation. Really appreciate it. Quick question is, so when you go out, when mobile crisis goes out for a call or has an interaction, is it required that law enforcement be involved, or is it something that you have to request, or that you choose to request? Is it a requirement, or is it a requested thing by the clinicians or whoever's going on in the call?
So the protocol for the mobile crisis response team is that if a call comes in, they have to assess for safety. They're gathering the information. Once they gather the information, they request the local police department for a civil standby just for safety concerns.
So the police will always, the law enforcement will always be involved in a call.
Yeah. Well, let me finish. If it is assessed and law enforcement are out, law enforcement and mobile crisis team are going to consult with each other. Law enforcement may be the first responder to the door, assess for safety, and then depart. That's just for the safety concern of going into a situation and not knowing what you're getting past the front door. I've been doing this work for quite a while. There have been some calls that have involved law enforcement, and there have been some calls that have not. The only time that there's calls that have not is if I had an extensive rapport with the individual where it has been assessed prior that I'm going into a safe situation. There's been situations to where I have been into where it has went left. And there are situations that may, that had the potential. So it's always looked at as that, we don't want anyone to get hurt. We're not sure of anybody's current mental state or if their substance is going to be able to cause them to you know, kind of have an altered mood at the time that they see an individual that they're not familiar with. So it's more just a safety.
So it's not a requirement to have a law enforcement.
It's the protocol of mobile crisis to assure that they have their safety covered prior to them going.
So there'll always be a law enforcement component to that.
And that's what Suzanne was mentioning earlier, was that the goal is for them to be able to make an assessment and determine if law enforcement needs to be there or not. And that's still in the works as far as it is with safety, you know, for the clinicians that are going out. So
there are some times where it's assessed and there is no need for law enforcement.
Okay. Correct. You're right.
Okay.
And that's the model for the adult response team. As I was mentioning, the one for youth services starts out without any law enforcement involvement and are only called to assist if the situation really escalates. But usually it's if they need assistance with initiating a 5150 hold. So yeah, the three teams have these distinct differences between them. So.
Thank you for the, I appreciate the answer. Thank you.
And often law enforcement will initiate the call out to mobile crisis. So that's the flip side of this. There's no requirement that happen.
Right. That's what I was asking. If there's a requirement, that's all I wanted to.
Yeah, officers will get on scene and determine that they're not the appropriate response. They'll try to get the situation stabilized for mobile crisis to respond.
Great. Thank you. Appreciate it.
So depending on the team is going to depend the law enforcement presence and how that presence will be. With the mental health evaluation team, it's a little bit different because law enforcement is with the clinician. So the clinician and the law enforcement officer, which is acting as a mental health officer, is not going to a home for criminal. Most of the time they're dressed down. You know, the approach is a little bit different, and they're not going in as far as saying, hey, I'm here for any criminal offense. They explain what their role is. They're a wellness officer, a community officer. They're only here for the safety of the clinician. And then they may step back and allow the clinician to go ahead, interact with the individual. If the individual doesn't feel as if they're comfortable with law enforcement, then we've had it to where the individual may say they're not comfortable with mental health. So it can go either which way, just depending on the situation at the time.
Yes, definitely. Thank you.
Okay, Randy is next.
Hello, thank you for your presentation, everybody. I learned a lot. I have a couple of questions. How much was the budget for the Contra Costa mental health that chart you showed in 2021? How much was it total?
Hi, Randy. So for all of behavioral health?
Yes.
I think for 2021 was about 175 million.
Okay, 175 million. Thank you. And then, so I heard that the calls either come from somebody from a family member, or say it comes through the police. Also make calls to you guys for requests to come out. Is that correct?
That's correct.
Okay, that's the only. And then, what is other than funding? Well, it's basically funding. That's why you say you want to go 24 hours. Do you guys know how much time do y'all spend in Richmond, or how?
Oh, we do. Well, in terms of hours, no, but we do track where we're receiving calls and where we're responding. And that's a good question, Randy. I usually have those charts with me, but I don't think we included them in this PowerPoint. But
Okay.
we do have it broken down by region and even by city.
Okay. Thank you.
Yeah.
Is there a way I can get that information? Because that would be very helpful.
Yeah, James, will you help me remember? I know that we have the data.
Yeah, Natalie has the data for that about how many calls for service are within the Richmond area. It may not have blocks of time that are in it, of time that they spend, but most of the time that there is a call for service and they go out, it can range between 30 minutes to an hour and a half, just depending on the necessity of the individual at the time.
Yeah, it depends on how complicated it is. We responded to one crisis call in San Ramon, and it ended up taking a very expanded team, and they were there for most of an afternoon. So that's not the best situation, but it can go that way sometimes.
Yeah, and sometimes depending on the length of the time that someone is out is the de-escalation time that is needed. So I've been out on calls where it has been 3 hours. The person has de-escalated, but still was a safety issue. So they did go to psychiatric emergency because it was a safety concern for them to remain in the home. Not that they were combative with law enforcement, but law enforcement did take the time to allow the clinician to be able to evaluate for that time, educate the family, and develop a plan prior to them going to psychiatric emergency. And after that stabilization and psychiatric emergency, they never returned to psychiatric emergency because there was a plan put in place. The family followed through and they followed the directives of the mental health team. So it can go whichever way. It's more so of if it's very quick, that means that someone's in a manic state. That means that there is no conversation that could be had at the time, and they need to be stabilized as soon as possible to get them to the hospital. If there's someone that we're able to have a conversation with, they're able to develop a plan, a safety plan, they need to get immediate mental health services. We can plan that with the family. The family feels safe. Law enforcement at the same time feels safe. Then we can execute and take it to the next day and then have follow-up. So it's just depending on the severity of the call at the time.
And there's real differences if we just look at PES, who comes to the kids that come, the youth that come to PES and the adults. The great majority of youth who come to PES, the most common presenting issues are depression and suicidality. When we look at the adults coming to PES, that's certainly in there, but also we're seeing more episodes of psychosis, agitation, aggressiveness, etc. So there's a pretty sharp distinction between the kids and the adults at PES.
Did that answer everything?
Was that for me? Yes, it did.
Okay. Deborah, you're next.
Yeah, I apologize. I'm doing this. Somebody decided to call in sick, and now I'm at work and trying to pay for me. So I got a
We're
customer.
glad you're multitasking with us. Deborah, your turn.
Hi, thank you. That was a really great presentation, very thorough. I'm glad I was able to download it so I could look at it at the same time and actually follow it. So I appreciated that. I have a couple of questions. I'm going to pose them in a somewhat organized fashion. First, having to do with substance abuse services, then mental health services, then budgetary issues. So with respect to substance abuse services, I was listening for what you're doing in the realm of harm reduction services and or overdose prevention. I was kind of listening for that. I didn't hear much in relationship with that. And so I'm interested in the overall plan that includes that issue. Are you actually going out to people? Do you have anything that does needle exchange? Do you provide crack kits or any harm reduction for people who are stimulant users? Do you provide condoms for sex workers, like anything in that realm? Do you have places for people to come before they get into crisis that can be an entryway for them to get into treatment, which is something that many cities have found successful in addressing people who are hard to reach and maybe not as open to traditional drug treatment services. So that is in that category. With respect to mental health services, I was really listening for two things. One, cultural competency, like who are the people who are staffing these services? How are they interacting with people? A lot of the resistance to accepting support has to do with people not being culturally competent. That's something that we heard in our community listening sessions, that people didn't feel that the folks that they could reach out to understood them, could speak to them appropriately, and were there to support them outside of a space of crisis, which is always the most difficult thing to deal with. So what kind of support is there for families, for adults and youth, that supports them in accessing services when they're not in a space of crisis, particularly with young people in response to adverse childhood circumstances? Where is services available to them? Do they have to ask for it? Do school-based services actually bring to the attention of folks, kids who they know have had these circumstances that may impact their mental health? And then finally, on the issue of budget, I heard a lot of conversation around money from the county and money from the state and money from the feds, but it's not clear to me how much money the city of Richmond is actually investing in these programs in comparison to other things that are funded. And I know that's a lot, so if you want me to repeat any of it, I will.
Well, you were very thorough and very organized. People make fun of me because when I write, I always 1, 2, 3, 4, 5, 6. They say you don't need to put numbers on everything. But Fatima, why don't you take those first set of questions?
I will try. And please, if I skip something, please let me know, because it was a lot. Thank you for the question on harm reduction. Suzanne explained that our funding comes with a lot of strings attached. So one of the strings attached for our funding is, and there's a clause in the contract that we received from both the federal government and the state, and that is that our funding should never be used for harm reduction approaches, which is very interesting because at the same
Who's I'm sorry to interrupt, but whose decision was that to put that exception in there? Is that a federal or a state one? I'm sorry, I just wanted to know.
It is federal, because our funding, the majority of our funding is federal, and it passes through the state and it comes to us. So the state, to some extent endorses that for substance use treatment specifically. Now, we are under a larger umbrella that's called Health Services Department. Within that umbrella, there is a department that is called, there's a division, not a department, that is called Public Health. So substance use and public health historically have worked together on a number of initiatives. Now, let me backtrack in terms of harm reduction. Medication-assisted treatment could be considered a harm reduction approach because we treat the individual according to their needs, and it's not necessarily just counseling, it's the medication as well. In terms of addressing the opioid epidemic, we have a blueprint as a department, and that is how we treat the opioid epidemic. And within that, substance use has had a role in mass distribution of Narcan within the entire Contra Costa. And within that approach, we have targeted specific areas, for example, or units or locations. For example, homeless shelters, where we know people may be at a higher risk. All of our providers in all of our treatment facilities, for anybody who states is an opioid user, everybody's discharged with a Narcan spray. All of our mental health clinics, all of our mental health providers have a stock of Narcan spray, because we know that can occur. In fact, I just deployed a few boxes of Narcan spray to the forensic team for their mobile teams, because we know that crisis, it could be a place where we can utilize a harm reduction approach. So, in terms of needle exchange, that happens through public health, and they contract with 2 different entities where the needle exchange occurs. Our advisory board, the Alcohol and Other Drugs, has an advisory board, and there's advocates for harm reduction approaches, including needle exchange. That has been a movement that has taken place within them as advocates, but not necessarily in relationship to us, because our funding, we could be putting our funding at risk. And I don't know if I responded to everything. Did I skip something?
Sex worker harm reduction.
That also occurs through public health. So there are many efforts, and I'll be happy to send information about that, but that doesn't happen through substance use. It occurs through public health.
Thank you.
You're welcome.
And then I had a question about the budget, like how much money is the city of Richmond investing in in these services and programs separate from federal, state, or county money?
At this time, the cities aren't contributing, none of the cities are contributing towards the mobile crisis teams. Now, for the core teams, the core members addressing on people who are unsheltered, the cities are helping with subsidizing those services, but not for the mobile crisis teams at this point.
Thank you. And finally, I really appreciated the chart that you showed us outlining all the services for West County. And I'm curious about how that compares with services that are available in the rest of the county, particularly in respect to preventive services as opposed to crisis services.
Sure, we have those same service maps for each region of the county, and I'd be glad to forward them. I didn't want to bombard you all with so much information. There definitely are differences. In some regions, it's a little bit heavier on adult services, and others a little bit heavier in children's services. And then the school base, there's some differences in how many schools we're in as well. But we can send you those as well for the other two regions. And Deborah, I think you asked a whole series of good questions, and one you didn't just ask me about, but I want to loop back to is really the whole thing about social justice and equity and the workforce and cultural competence. And when I think about cultural competence, there's certainly linguistic capacity that's always focused on as the number one. But then it's the cultural competency, and there's so many different cultures, including the culture of behavioral health clients, which isn't always recognized or well understood. And I think it's something that we're looking at, we're addressing. I'm very committed to us advancing in that way. And what I would say is, I come from a continuous quality improvement standpoint. I think there's more we could be doing on that front, quite honestly. I think we're making our best efforts, but there certainly is more that we could do. I know that we're in some discussions, and I don't know where we've gotten so far with Ken Hardy, because I would love to have him come in and start doing more equity work with the behavioral health staff as well. So I think always room for improvement and growth in that area.
I really thank you for everything. And I just want to point that, part of the reason that we're here is in response to the issues that continue to persist around institutional racism. And one of the ways that shows up with respect to mental health and substance abuse services is an expectation that Black and Brown people only need services when they're in crisis or they're in conflict with the law. So the ability to access services when you have adverse circumstances or dealing with general depression, have not had those problems, is almost non-existent. And I think that one of the things we need to really get to, that I'm committed to, is to have poor people and people of color be able to access the services and the support that they need in the same way that affluent communities can, so that they don't have to be under some form of criminal justice supervision or other state sanctioned supervision. And I'll stop with that, and thank you again.
Yeah, and I want to thank you for those comments. I'm very much in agreement with that, because we can pull up all sorts of charts that with demonstrating demographics of who we serve and people of color, what percentages, and what I always say, that's okay, that's okay. But let's look at where people are receiving those services and at what level. And are they really receiving services at the appropriate level? Pretty much to what you were saying, like we can say, yes, we're serving X number of people in this category, but are we serving them in the best place at the best time? And I think that's where we continue to look at ourselves and figure that out more and more.
And I do want to say that I have talked to Gilbert, I believe his last name is Salinas. He is, I don't know his exact title, but he is on the county health's race equity, like he's a race equity officer. So he and I are discussing like a way for him to bring some information forth to you all. But I just wanted to mention that really quickly and then go on to Ben Terrio. He's next. Ben. Ben, going once.
Yeah.
Oh,
I'm here.
hey.
Sorry. My question has to do with the how you guys employ MCRT and into West County, and like what would it take to basically integrate more of a responder model of MCRT with the West County and have tighter integration with Met, and then also with dispatch, that seems to be the big problem is what is it going to take for 24-hour dispatch, because that's really something that is a hindrance, is the 24/7 operation of things, and that's why a lot of things go through the police department. Thanks.
I'll do part of it, and then maybe James could do the other part. So on that last part that you just brought up, that value stream mapping event that we just talked about, that quality improvement event that happened in November, that certainly came up there, and we've been really aware of it. To give people 3 or 4 different numbers, and they might be 7 to 10 digits long, it's not good. It's not great. And people will call 3 digits, and 3 digits are 911. And so one of the identified, there were 4 areas of improvement that were identified out of that whole value stream event. And one of them was having one integrated access line, point of access, and not have it be a long number, and see if we could get a short number, et cetera. So definitely agree with you on that. And then James, do you want to take that other part of the question? Whoops, James might be frozen or on mute.
Maybe while we wait for James, I can respond to the dispatching issue.
Perfect.
So, one issue within the rapid response, or having a rapid response model, is the integration of the communications infrastructure. So something, to keep in mind is that, say somebody calls dispatch and they're reporting that there's a mental health crisis, they would like assistance. Even if a dispatcher at this point believes that MCRT is the right response, dispatch, at least through Richmond PD, this time, they don't really have the time to spend 5 or 10 minutes on the phone trying to route somebody through that process, or to make the referral themselves. In the same way they wouldn't be able to make a Met referral most of the time. So there are some practical logistics to keep in mind about having kind of a federated system of dispatching, where you're not able to have the tight integration or rapid response without some further kind of organizational coordination. And right now, I think James can speak to that doesn't exist quite yet. And that would be just as true if you were trying to get AMR or fire to respond with MCRT as well. The same problem would occur.
Yeah, so I'm going to concur with Officer Landy. I have reviewed and been in communication with a lot of other entities. So I have been on Zoom calls and meetings with AMR, EMS, psychiatric emergency, law enforcement, when mobile crisis was being developed, in order to figure out what would be the best way to deploy units, or to be able to provide the communities with a lot of these services. And I'm not just talking about the city of Richmond. One of the major issues is that every city within Contra Costa County has their own unique kind of disadvantage when it comes to services that need to be provided. There is no one size fits all. And if you try to put a one size fits all approach into it, then it's not going to be successful. One of the things that Contra Costa County does is they look at the overall perspective of how something is going to be long term. Mental health evaluation team has developed over a period of time. One of the things that was not mentioned about the mental health evaluation team is that it's a law enforcement based referral only. So it's not something that the community is just aware of, and you could just go call anybody on the team and say, hey, I need your services. That's why the mobile crisis response team is available, so that you can call them, you can provide them with this information. The collaboration between the mental health evaluation team and the MET team is that mobile crisis is able to decipher and distinguish if this is an actual crisis or if it's something that needs to have a follow-up. And then mobile crisis and MET will coordinate, and then we'll figure out what's going to be the best approach for a follow-up response. And that's why the mental health evaluation team is in perspective at this time, because we're more so of like your mental health investigators. We're going to go in and figure out exactly what the problem is, why it continues to occur, why has law enforcement come out, and what's going to be the overall goal for the individual as well as the family, for the community to be safe, as well as public safety for everyone else. So we're not just looking at a one size fits all. We're looking at how we can pretty much make sure that everyone is going to remain safe because an individual is not in the capacity at the time. So there's more than just, getting a rapid response that's not going to be able to provide the overall services. There are services that are currently in place. So what we need to look at is the models that are there, and then figure out how they can either be expanded upon, or or the time frames of the hours of operation, or are there additional services that should be added at the time. And that's where you all play a major role, is because you are able to see this every day. So the services that need to be provided should be discussed, and then seeing what's already in place, and then saying, hey, maybe we need to end up partnering with the CBO because they're already doing this certain thing, or there needs to be an added clinician or another officer or a community support worker that's going to be able to bring value to our community that can provide these resources. So we're looking at a bunch of different models. And yes, in the future, there should be some form of rapid response model, but it has to be under one entity and one umbrella in order to effectively operate.
Yeah, and James, I think you've highlighted a couple of things, and as did you, Officer Landy, is that MET is really its own program. We include it in the 3 mobile crisis teams because there is that element, but it really is a very different model than the other 2.
Just to layer on that, one issue that does come up is that people are often fairly satisfied, I think, with the services that MET provides, but confusion about our role. And so, at least in my community, in the city of Richmond, there's often the expectation that I will be the one responding to a mental health crisis. And unfortunately, that's not feasible. I'm really part of that kind of, mental health kind of investigative follow-up. We don't have a, kind of first responder model right now. So I think the city of Richmond's fortunate that most of our officers are, competent at knowing when to make the appropriate referrals. But I think there are community expectations that they're going to get something more like the service they get with MET when they're dealing with an immediate crisis.
Yeah, thank you. I mean, that's another really important point, because many officers throughout the county have received CIT, crisis intervention training, CIT training, and it's a great first step. But when I was going around talking with all the different chiefs and their command staff, it was okay. That was a great intro, but we need more if we're really going to be actually more effective at what we're doing. And so that's something that we probably will be looking at going forward. Sort of like, what is CIT 1, 2, 3, and just keep advancing it depending on what people are interested in doing. So thank you.
Yeah. And with the MET team, so we are involved in the CIT training with law enforcement. We do participate in the training to provide law enforcement with mental health education. Alongside that, we do lineup trainings, and we do the internal CIT trainings for each department within Contra Costa County as well. Because of COVID, of course, we have been restricted from doing a lot of lineup trainings within the past months, as well as their CIT trainings. And what we pride ourselves on is making sure that the officers that we're presenting to, we give them the most updated information as far as it comes to mental health. So whether a psychiatric emergency form has changed to place someone on a 5150 hold, or if it's some new information that is relevant for them to be able to assist an individual better within the community. We would like to make sure that all departments have this information. So that's another part of the mental health evaluation team that the public does not see, is that we're behind closed doors providing a lot of this information and this education so that the community, law enforcement, as well as other providers within Contra Costa County are aware of the changes that are continuously happening.
Okay, we do have some other questions from the task members, and we also want to provide opportunity for the public to speak on this or ask questions or have a comment. And I want to make sure that all the members have an opportunity to engage with all the, not just the guests here that we have, but also other members of the task force. You all are resident experts, you're community experts. You all have something to contribute to the conversation. So I invite whoever has information to also respond. So next is Luis and then Tanya.
Thank you. My question should be fairly quick. First, I'm wondering, I know it was mentioned that the city of Richmond subsidizes at least one mental health service. Are there more? Do you have a list that you can share with us?
Oh, I'm sorry. Could you, not quite clear on the question.
So earlier when we were asking about how much money the city of Richmond is contributing to the mobile crisis team, you mentioned that no city is contributing any money to that, but you did mention that at least one other service was being subsidized.
Oh, I'm sorry, I'm not so sure about that. So the Met officers and Officer Landy is, correct me if I'm wrong about you, but I believe most or all of the Met officers are funded through AB 109 funding. The Met clinicians are not. They were funded through a separate grant, and that was the one that expired in February. So we've been, we built in the positions so that we didn't have to cut the Met clinicians. And it looks like Officer Landy's going to help us out here.
Oh, Michelle did make a mention, and I think you were talking about, Luis, the when she mentioned about CORE, the homeless.
Oh, that's right. Yeah.
Yeah, that's what she mentioned. So, and they will be coming to the February 10th meeting to present on their services. So,
thank you.
But Suzanne is correct that the Met officers are not funded through the city. It's through the AB 109 funding.
okay. So Tanya.
Okay.
Oh, thanks, Brian.
Or just one last question. Sorry.
Oh, sorry, Louise.
Go for
I
it.
thought you were finished. Pardon me.
My bad. Just in terms of the 24/7 response, I know it was mentioned that funding is a big kind of setback to that. Is there an estimate of how much it would take to have that implemented in the city of Richmond?
Oh, in the city of Richmond, that would probably be pretty pricey.
Yeah.
So when you think of 24/7 and it's a team of 2 people, so, you know, I used to be a nurse, so I always calculate these in shifts. So that's 21 shifts a week and times 2. So it gets to be a lot of staffing. So 24/7 for the city, it would certainly be possible. Whether it's affordable is another thing. We haven't been able to lift up 24/7 countywide because of the cost.
Okay, thank you.
Now, if we could get some commercial insurers or foundations interested, and I know Michelle, when we were talking last evening, was bringing this up, there might be other funding out there we just haven't tapped into or outreached for.
If I can also quickly respond. I know that there's a large desire for Richmond specific focus, but a lot of the clientele that we service in Richmond do move across jurisdictional boundaries. And so one of the advantages of having a regional focus, so not necessarily a countywide, but like the West Mental Health team, is that we're able to follow our clients as they move around the various cities. So James and I work with a number of people who move between cities quite regularly. We are able to follow up with them there. So it's just as important for in a kind of rapid response model for 24/7 service that you may want to have that officer or clinician, or if it's co-responder model, be able to move across jurisdictions. It also may facilitate some of the cost sharing across cities.
Good point. Tanya?
Yes.
Oh, I don't mean to cut you off, but I want to make sure that everyone has a chance. Tanya?
Yeah. Thank you everyone for the presentation. It was really insightful and I learned a lot. And I just have a quick request. I was wondering if there was a way that y'all can create like a list of recommendations, like based on, you know, your expertise and your experience out in the field of things that should be funded or programs that should be added, because I know there's a number of us in this group that are looking at alternatives and looking at things to fund. So I think it would be great to have a list of recommendations from experts in the field.
Yeah, I think that having a roundtable with you all and throwing out ideas, and then being able to see which ones are important, which one are focused on your area, that would, you know, be the start to being able to provide that information.
Yeah, I agree, James. And you know, every community is different, and it's knowing from within the community. You know, so for a while I was in Marin County, and what I learned pretty quickly is if you go to the canal in Marin City, that's a different part of Marin than the majority of it, and how important it was to get to understand those communities as they are and what their needs are and what they were really wanting. So I agree, James. Having a local discussion is always a good starting point.
Did you have anything else, Tanya, or is that fine?
That's fine. I know we're having the roundtable discussions. I guess I just mentioned it because I heard a lot of really good input, you know, when it was like, and then we should have this or that, you know, when just closing the loop on some of these services, it sounds like there's not a full loop, and so that there's some gaps that need to be filled. So I guess that's kind of what I was alluding to, like what are those like gaps that need to be filled to like really close the loop in some of these services.
Yeah, you are correct. And the gaps of services, the county has some information, I believe, Suzanne, from when they did that model about a couple years ago about our gaps in service within Contra Costa County that need to be addressed.
Okay.
Yeah, and that value stream mapping event that occurred in November was really highlighting a lot of those, and that's why the primary aim that came out of that whole countywide process was the aim was that every resident in Contra Costa County should have access to mobile crisis services, community-based crisis services 24/7. So that's the stated goal. And then how do we all achieve that?
And maybe too, we can also invite James or Officer Landy or any other individual to come to one of your roundtables or something.
If I can add something to what Tanya was saying, Johan, this is Fatima, is the fact that stigma is around, to the extent that this group can do some work about reducing stigma towards substance use and mental health is important, because sometimes we want to provide services in the community, but we're not wanted. And it all has to do with the stigma, and that is because society or communities always think that the best way to treat these disorders or diseases is through criminal involvement, and it shouldn't happen that way. It should happen through programs that are embraced by the community, but we do need your support. Thanks.
Thank you, Fatima. And Kristen, you are next, but I just want to ask the group if there is a consensus to continue the meeting, and if so, for how long?
I move we extend
for 30
for,
minutes.
thank you. I second that.
Okay, so go ahead, Kristen.
Is that a consensus?
Oh,
2 people? Sorry.
Well, it sounded, I mean, Ben, do you want to say
It was just a
that?
motion. And a
Okay, go
second.
ahead. Is there opposition to this consensus?
Why don't you ask all in favor, say aye, or raise their hand?
Okay, I just, because that sometimes often doesn't work, but if people are willing to raise their hands now to go ahead, then we'll give it 10 seconds, 13 seconds. I'm not even sure how many people we have here. 1, 2, 3, 4, 5, 6, 7, 8, 9. 10, 11, 12. Well, based on the members that are here, there is a consensus. I know David Tucker says he has to leave, so.
And Joanne, I'm sorry, I'll have to leave about 1:15 because I have to prepare something for the Board of Supervisors. So.
We appreciate your time. You've
Sure.
spent your evening with us, so thank you.
Oh yeah, no, I could stick on a little bit longer.
Okay, Kristen, go ahead.
All right. Wow. Thank you so much for being here and giving us this incredible presentation information. I really appreciate it. So, and Fatima, thank you for that. You know, you had the perfect lead up to what I was going to say. I've been a recovery advocate in this community in Contra Costa County for about 8 years, and I'd love to see more data, but I can tell you just, I'm sure it's no surprise, we do have a lot of inequity in our county around who gets treatment and who is being criminalized. And I think that's, you know, why I'm doing this work. It's really important to me. And I appreciated what Deborah said around cultural competency as well. So that's just a comment. And then I wanted to tell the folks working for the county that there's a lot of Richmond activists, and Richmond, the Richmond community would really like a seat at the table, a lot more of these county level meetings. Like if we do have city staff or maybe heads of programs, directors of programs attending these meetings right now, there's like sort of no mechanism of how that information is received in the community or amongst this task force, or so there's really like a disconnected communication. And since we're all here together right now, there's 33 of us. I just thought I'd put that out there as something for us all to think about around how us folks in Richmond really know what's going on at the county level and get invited to these the meetings that you're having. And I think that's important.
That's a really good point, Kristen. And you know, for there are 2 representatives on the Mental Health Commission, at least 2, representing West County. And so they're your conduit into the Mental Health Commission, where a lot of advocacy goes on. And the other place is called the CPA group, the Consolidated Planning Advisory Work Group. That's the Mental Health Services Act Advisory Group. And I know that some members from West County just joined there also. So there are some standing structures where there are representatives from the region, but I don't know how much they're relating back to you all in the region. So just wanted to raise that thought.
Thank you. Thank you so much. Yeah, I don't know who the 2 West County representatives are on that board.
We would probably assist you with that information.
Thank you.
I'm on the board of the MHSA also, so I'll find out who those representatives are for West County for you.
Yeah. Thank you.
Okay. Did we have any other members that wanted to ask questions or speak to the panelists? Okay, well, we are going to go ahead and open it up then for public comment. And the Attendees will have 2 minutes time period to raise their hands, an allotment of time to raise your hand. And during that time, we will take speakers as they first come, and they will have 1 minute apiece to speak. So Stephanie, can you please start the 2 minute time period? And Lupe, I think we have a speaker.
So we have one speaker so far, Carol U. Johnson. Carol, you have 1 minute. You may go ahead and start.
Okay, can you hear me?
Yes.
Yeah.
Oh, I want to thank you for that great presentation. And my question is, what is the percentage of calls that don't necessarily need police, their direct involvement, but just for them to stand by? That's it.
Oh, okay. Thank you, Carol.
Oh, okay. Carol, are you, I'm sorry, are you asking about people who call in requesting mobile crisis response, and how frequently law representatives from law enforcement participate? Is that the question? Or maybe I didn't
Well, I
understand
know
it.
they're there. I know they're there for civil standby, but how many? What is the percentage of times when they really need to step, more directly, getting involved, and as opposed to just letting the mental health workers handle the situation?
That's, yeah, James, I don't know if we have it broken down that way. We might, by way of the calls that come in and how they're triaged. I'm not sure. We could look into that a little bit and see what we could do. I don't know off the top.
Yeah, the first thing, I'm sure if Officer Landy is still on, but he may be able to respond regarding the city of Richmond, the calls for service that come into dispatch, and how many have been filtered that do not need law enforcement response. That's going to be your overall. But then we can provide you the mobile crisis information at a later time once we gather that from the supervisor.
I think that's going to be a little bit of a difficult question to answer. And that's probably because you're talking, we don't really know. For example, if you look at Richmond Police Department's dispatch, you have, well over probably about 1,600 calls for service for mental health last year. How many of those also got referred to MCRT? That's something that we'd have to figure out. I don't know, that would require merging of quite different data. There's also the issue of, the Richmond Police Department gets dispatched to events that are not initially triaged or classified as mental health, where a police officer shows up and makes a determination that there should be an MCRT call out, and or they realize that they need to respond immediately due to there being some kind of psychiatric crisis and a hold gets placed. So just to give you a very general sense, only about half of the 5150 holds that are placed by a city like Richmond actually come from mental health calls. So there's not going to be a perfect overlap between police response, MCRT, without kind of doing a fair bit of kind of data legwork to figure that question out.
Yeah, and one of the kind of follow-ups that I think that the community would like to see is if this is information that's being asked of from the city of Richmond, then that's something that we can look further into to be able to track this information just for the city of Richmond. What I look at it as is the mental health evaluation team was a pilot for the city of Richmond. From that pilot, it was developed a program that has lasted 6 years and has superseded the expectations of what anyone thought that it would be, with mental health and law enforcement joining as a partnership. Having the Richmond Police Department pilot additional programs that would be able to cater to the community is what we would like to see in the future. If they need to be involved with Costa County in order for there to be an alignment of the services, then that would be a larger conversation that Suzanne and the chief of police of Richmond PD would need to have in order. So the information that you're requesting can be given. It's just going to take some time. A lot of the feedback and a lot of the services that you're looking for are going to come from that larger conversation on what the city of Richmond needs, so that we can be able to provide it between all of these entities. You have the community, you have law enforcement, and you have mental health. We need to figure out how we can merge this together and then have the responses that are needed for the community, and then be able to branch it out to the rest of Contra Costa County, because Richmond is not the only city that would need these services.
And to add to that again, I mentioned it earlier, really appreciated Michelle reached out, and we actually did have a conversation with the chief last night and hope to have continuing conversations. So I know that she's very thoughtful about all of this.
Okay, so are there any other final questions, comments? If not, we can go on to some recapping. Let me make sure I'm in the right spot on our agenda before I say anything.
If I could say, because I'm gonna have to leave and do some writing, but if I could just take a moment to thank you all so much. I really appreciate you inviting us, and it's really, your questions were really thoughtful and stimulated a lot of thinking, and just this discussion has been really helpful to me. So thank you so much. Really appreciate it.
Thank you so much. Did anyone have, oh, I know, we really appreciate you taking your time, spending your evening, meeting with me beforehand. It's always good to know that you all are available to us. So thank you again.
Thank you.
Are there any general member comments that people would like to add right now? Otherwise, I just want to make sure that we have a couple items that you all requested for some follow-up, is to get copies of the value stream mapping, it sounds like, from for the entire county, in addition to getting some service maps for all the regions, and perhaps working together in the future around creating a list of shared recommendations, and then getting information from the public health side as well. Is there anything that I'm missing? Okay. So if anyone,
Can I?
Oh,
I
yes,
have something. Now that we are connected, if there is anything important or pertinent that you think this task force would have value in attending any of the future meetings, would you all be able to email Joanne, and she can then contact us if we'd like to attend?
Sure, we could ask both the Mental Health Commission, and the other group that's been meeting regularly is the Behavioral Health Community Partnership, and that's co-chaired by Jen Tupelo-Tu, our Director of Office of Consumer Empowerment, and Gigi Crowder from NAMI. So we could ask to, maybe, I don't know, Joanne, how much you want coming into your email, but we could ask those 3 different groups to add you to their mailing list, and then you would be aware of what's going on.
That would actually be perfect.
Okay.
So if you can do that, I would appreciate it.
Sure. Yep.
Okay.
I can add the Alcohol and Other Drugs Advisory Board, Johan, and you do have representatives from West County District 1 in the board.
Okay, great. That's perfect. So I'll be on the listserv for 4 different groups, and I will definitely disseminate that information to you all.
Thank you.
Okay, so if there are not any other comments or questions or any other action items or recapping. Hi, Deborah.
One quick question. I just, I'm sorry, no, very quick. I just want to know if people feel that there may be some changes in direction, specifically with respect to substance abuse and mental health services under the new administration, because they have elevated these issues as areas of concern, particularly with respect to substance abuse treatment. I'm thinking about what you said about the prohibition against using harm reduction, et cetera, that was coming from the feds. So do you guys anticipate changes? And if so, what are you putting in place to be able to respond to that?
So I'll start the answer, then Fatima can add to it. So what we do is start locally, and then really our largest advocacy voice, we're members of the California Behavioral Health Directors Association, and that really is our advocacy, our statewide advocacy forum. That's how we negotiate, I'll say, most effectively with the State Department of Healthcare Services, and also increasingly taking some positions in advocacy at the federal level also. So that's the process that we have in place currently. And Fatima, do you want to add to that?
No, I think you're right. All alcohol and drug administrators at the state level, from all counties, we are all in favor of harm reduction. We think is part of the continuum. We also think it's very important with some populations. For example, with young people. Young people don't necessarily want to go to treatment. They don't acknowledge that they have a problem. It's even difficult for adults, but adults, we all know that the problem starts getting worse in their circumstances that helps them recognize that they have a problem. But young people will never agree to that, and we don't want to force anybody. We also think that there's another model which I'm really very much in favor of, and that's a sovereign center where people enter not necessarily because they have treatment. They enter because they just want to sober up, and that's all they want to do. And that is very helpful for people who you see typically intoxicated in the corners. That's a harm reduction model. Our funding does not allow us to fund that. So there are things that we are very much in favor, and we will continue advocacy towards that. And we use the behavioral health directors, and Suzanne is one of the greatest. So we just use those steps to get where we need to get.
So I just want to draw your attention to, there was a really effective treatment model implemented in Delaware when Beau Biden was Attorney General. That was one of his priorities, was improving substance abuse treatment. And they actually implemented a statewide model that was consumer driven. So the measures of success was based on the satisfaction of the users, of people who had drug problems who were going to these services. And it really changed the way that the programs operated, where their spaces of interventions were, et cetera. And I just think that one of the problems about the current system is that it's not consumer driven. It's agency driven. And so I just think that one of the possibilities presented by having a new administration with a president who understands these issues is to shift the way that we deliver these services so that they're more responsive to the people who are consuming them and meet their levels of satisfaction.
Thank you.
I do want to give a shout out to the county, because when Contra Costa County opted into the Medi-Cal waiver system, there were many meetings with the consumers in the community on developing the plan. This was a couple years ago. The services.
Well, thank you. Thank you for that, Kristen. Thank you for all the comments. I really appreciate everyone being here. We all appreciate each other. And I would like to end this meeting with a little quote that I ran into today. If you are more fortunate than others, build a longer table, not a higher fence. So let's just close out on that, and have a good evening, everyone. And we will see you soon.
Bye.
Good night, everyone. Stay
Good
healthy.
night.
Bye.
Good night, everybody. Love you all. Bye.
Bye.
I'm not getting
Do you want to stop the recording?